talking today about adults with CP. Cerebral palsy is my specialty, and I am in the Cerebral Palsy Center at WashU in St. Louis. And I'll be talking about it in the context of ongoing neurologic care, but in the context of cerebral palsy itself. I have no relevant disclosures, but these are my full list. So the first thing I want to talk about is what is CP? How do you diagnose it? Why should everybody on this call care? And then I'll be talking about neurologic manifestations of CP, not just in childhood, but across the lifespan, specifically focusing on new neurologic manifestations of cerebral palsy in adults with CP. So these aren't things that they've had their whole lives. These are things that show up new that require a neurologist to screen for and surveil in adults with CP. This is the consensus definition of CP. It's been longstanding, has been out since 2006. And I have it up here, and I have it up here in a lot of my talks because every word in this consensus definition is important. So CP is a lifelong condition, and I say that not just in the context of this talk, but in the context of all talks. In the US, the majority of people with cerebral palsy alive today, the majority are adults. So this is not only misinterpreted as a pediatric disease. If anything, it's an adult disease. So it's something that we need to take seriously in our adult provider population. CP is a motor disability. So even though we'll talk about multiple manifestations of CP and associated conditions, to have this diagnosis, you must have a motor manifestation that causes a functional limitation, that causes a disability. It is by definition non-progressive. Now, this gets sticky when we talk about adults with CP. One of my colleagues at Hurwitz, who's a physiatrist at the University of Michigan, says that life is a progressive disease. So when you think about this in the context of CP being non-progressive, there are some grains of truth to take into that as we think about the adult with CP, but also many adults with CP face what we think is an early aging phenomenon. And we'll talk about how that might manifest in terms of neurologic things to screen for. It's due to a disturbance, and that is intentionally vague because that disturbance can be inherent, it can be acquired, it just must occur in the developing fetal or infant brain. So it has to occur early in life, can be any sort of disturbance to that developing brain in that time window. And as long as the phenotype, at least during childhood, is non-progressive, and has a motor disability associated with it, you have cerebral palsy. The impact of CP is high. CP in the US affects 2 of every 1,000 people, and that is comparable to the prevalence of Parkinson's disease in this country. And so just think about the educational offerings we get from neurologic organizations about Parkinson's disease and the relative lack of education we get about conditions like cerebral palsy. This is just as common, requires just as much of a focus. The costs for CP are high. So if we think about the medical and medical associated costs that people with CP born in any given calendar year, this is just people with CP born in any given year, single year, accrue over their lifetime, it's $12 billion. $12 billion per the group of people born with CP in any given calendar year. Not focusing on this population is a social mistake and an economic mistake. And as I said before, the majority of people with CP are adults, that's over 18. If you think we're just talking about young adults, that's not true. Over 40% of people with CP are over the age of 30. So now we're hitting older and older populations, people that are maybe should be commonly seen in adult neurology clinics. The diagnosis of CP is the way we're thinking about it is changing, and we've been lucky to be a part of this conversation. We published a paper a couple of years ago in pediatrics looking at how CP diagnosis might be variable. And we did this by surveying physician experts in cerebral palsy across North America from 2 different neurologic and cerebral palsy associated organizations. And I bring this up because these diagnostic dilemmas may persist in the person with CP that you evaluate in the adult clinic. So as I present these hypothetical scenarios, these are scenarios that we posed to experts in CP across North America. I'd like for you to think about how you might diagnose the person in these vignettes yourself. we presented a vignette of a 5-year-old child with a chief complaint of difficulty walking. And they had an MRI done. It had a pattern consistent with what we might think of for neonatal brain injury, periventricular leukomalacia. They had a history of being born premature. There was no genetic cause specified for that child. We were very clear that their motor disability was not progressive at that age, at 5 years old, and they had spasticity in both of their legs. And as we might expect, the majority of people would diagnose this child with CP. Now, if we gave people the same exact scenario, in this case it was scenario 3 of this list, gave them the same exact scenario, but just identified a genetic cause for the same exact manifestation for this child, the number who would diagnose CP in that child dropped to 67%. And when we asked people to specify why they had certain diagnostic preferences, 40% said they would not diagnose CP in the setting of a genetic etiology. And this should matter to all of you. And this is a problem because the way we think about CP and the way the definition is written, the definition that I laid out to you from 2006 onwards, this is not a new thing. Cerebral palsy is a clinical and not etiologic diagnosis. It's a lot like epilepsy. You can have epilepsy due to a genetic etiology, due to a traumatic brain injury, due to an acquired brain lesion in the setting of a tumor, in the setting of any of these different things. Cerebral palsy should be diagnosed similarly based on the phenotype. If you have a non-progressive motor disability that's existed from a disturbance to the developing fetal or infant brain, you have cerebral palsy. And the genetic etiology does not exclude that. Specifically in the context of the adults you may be seeing in your clinics, many of these adults missed the so-called genetic revolution. So that means that they may be carrying a diagnosis of CP, but not know why they have CP, may not have an etiology associated with that. And the value of that from a just knowing, as a person just knowing is high, but it also has a lot of value in terms of screening for coexisting conditions for that person. And it also has value in terms of family planning, which is something that we think about. But in terms of change of management, the value is high. And I'll get into the numbers for that in a little bit. It's also possible that a person with CP or a person who's given a CP diagnosis in childhood may have over time manifested a progressive phenotype and actually have a CP misdiagnosis. So seeing people with CP as adults, with CP, the diagnosis as adults, and really making sure that the etiology is confirmed is critical to making sure that they're getting treated appropriately. And this is a skill set that neurologists are particularly poised to contribute to. So we should really be thinking about recruiting this population to our clinics. 30% of adults with CP in at least one study may have genetic etiologies. This is out of a genetic testing study out of Columbia. And if you think that these are just people that, you know, may have other very clear-cut findings that might make you think they have a genetic diagnosis. So their brain MRI is normal and they had a clean birth history, or they have multiple other what seem to be congenital developmental issues that may go along with the genetic diagnosis. Now, in that population, the likelihood of a genetic etiology is higher. But even if you take people with CP that seem to have a reason, an acquired brain injury reason for why they have CP, the yield of genetic testing for finding a contributing etiology is 8%. So that means that if you see someone with CP in an adult clinic and they say, I have CP because I was born premature, and their brain MRI looks like it matches that, 8% of those people might still have a genetic contributor to their diagnosis. So thinking about this is incredibly important for, again, establishing etiology, treatment, and screening for the people with CP that we see. This was a relatively recent guideline put out by the American College of Medical Genetics and Genomics, saying that whole exome and whole genome sequencing should be first line etiologic evaluation for people with developmental disabilities. This includes CP, it includes autism, It includes early life epilepsy, it includes early life intellectual disability, and all of these things persist across the lifespan. And they also note that across a broad and really robust meta-analysis, that this testing changes acute or long-term management 8 to 10% of the time. And we're not just talking about family planning, which is what I think most people think of genetic testing being useful for. And it is useful for that. But separate from that, 8 to 10% of the time, the way you manage someone, the screening you do for other coexisting conditions, and the treatments you might select for them are directly impacted by the results of genetic testing 8 to 10% of the time. We should really be thinking about sending genetic testing for this population. And the people that are best at phenotyping this population, the people that are best at getting at the diagnosis, the etiology, that's us. So this is on us. This is something that we need to be doing. We recently published in JAMA Neurology a yield outline for whole exome versus CMA for cerebral palsy. And if you look at the meta-analysis, this was work that was spearheaded by Sid Srivastava at Boston. The diagnostic yield for whole exome in people with CP was about net on average. Down here, you can see this overall random effects model for people with non-cryptogenic CP. That means people that have a potential acquired brain injury etiology of CP. That's here at 25% high. If we think about that for the CMA, the yield is much lower. And you see that in the random effects model down here. So we're now talking about down at 5%. And based on this, we recommended kind of a flow chart for how you should think about genetic evaluation in people with CP. So step one, doing a complete clinical evaluation. And for a neurologic condition like CP, again, we're well poised to do this. And then whether they have an acquired brain injury or not, as a part of their CP diagnosis, to think very critically about whether that history matches with their phenotype or whether there could be a mismatch that might trigger you to do a genetic evaluation. Then the preference is to do whole exome. If whole genome is not available, for most of us it is not. Follow that up with the CMA, depending on the coverage of the whole exome for copy number variants. And if there are questions about this, I can talk about it a little bit later. And then critically, every 2 to 3 years, making sure that this genetic information gets reevaluated through the place where you sent it. And that's because our knowledge of genetic contributors to CP is changing, or at large to anything, is changing so rapidly that 2 to 3 years from now, the way that whole exome data is interpreted is likely to be drastically different than the way it is interpreted today. So just because you sent genetic testing today, or just because someone with CP had genetic testing 20 years ago, does not mean that they are now home free and should not get any more genetic testing or should not have that revisited. This is something that is important across the lifespan. And again, because phenotyping is so important for how we send and inform whole exome results, it's an important way to inform whole exome results. The phenotypers are us, that's us. So this is something that we need to take on as neurologists and as adult neurologists for this population. Example viewpoints for why physicians may not want to give someone a cerebral palsy diagnosis in the setting of a genetic diagnosis. So some folks said that a genetic diagnosis is more specific, more appropriate. Another comment, cerebral palsy is a bad term. This was not an uncommon sentiment that we heard in our survey. And then the last term, I guess the general neurologist would call it CP, but given my genetics training, I feel it's more of a bucket diagnosis. And I don't know that we'd say this about epilepsy, right? So why should cerebral palsy be any different? This should be thought of comparably. These are neurodevelopmental disability cousins, and we should treat them the same way. As a kind of response to this, after seeing that this is how physician experts were thinking about a cerebral palsy diagnosis, we asked people with CP, and a large majority of the 200 people surveyed across North America were in fact adults with CP. More than 50% were. We asked them what they thought about a cerebral palsy diagnosis. 75% wanted to know what caused their CP. So this is this is something that this population valued. But less than half had been told the cause of their CP by a medical provider. I mean, ouch. This is something that we are really capable of remedying and something that this population really wants. And perhaps most importantly, from this study, in response to the previous study I showed, the majority, 68%, wanted to have both diagnoses together. And if you ask people which of the two contributed to various aspects of quality of life for them, various aspects that they might find would be valuable to them in terms of a diagnosis. Overall, the diagnosis of cerebral palsy was more likely to be seen as valuable by a person with CP for understanding the evolution of their symptoms, for being able to explain their condition to others, for being able to access services, and for gaining access to a community, which is a data-driven way to improve quality of care, health, and well-being in people and caregivers with CP. So overall, giving people a cerebral palsy diagnosis, affirming that diagnosis, and identifying the etiology is critical because it's what people want. It's what our patients want. And thinking about that is really important in terms of establishing a care relationship and providing good care for this population. Okay, so we've talked a lot about cerebral palsy diagnosis, genetic etiology evaluation. Next, let's talk about the neurologic manifestations through adulthood. I talked about CP being lifelong. I talked about it being high impact. This impact is lifelong. Adults with CP have twice the risk of stroke and 8 times the risk of myelopathy compared to age-matched adults without CP. They also have 9 times the risk of ADRD, dementia, and 9% of adults with CP will develop, having never had a seizure in their life, new onset adult epilepsy. Now, knowing that the risk of epilepsy in the general population is about 1% or less, 9% adult onset epilepsy is high. So thinking about screening for this and thinking about this when you see a person with CP in clinic is important. In addition to these kind of more clear-cut neurologic manifestations of CP, there are also these other manifestations that are critically important for function that can have neurologic contributors. So a third of adults will lose some degree of mobility. 65% of adults with CP will note that they have functionally limiting chronic fatigue, and 60% will note functionally limiting chronic pain. And these are things that develop over time that have potential neurologic manifestations that neurologists, and we as neurology providers should screen for. I'm going to break down each of these components into its parts. So thinking about stroke, I said they have twice the risk of stroke. So that's 2.3% in matched controls, but 4.6% in adults with CP. But when adults with CP have the stroke, they have twice the mortality rate. So thinking about stroke management, stroke prevention in this population is important. We also know that adults with CP have kind of the so-called metabolic syndrome or a higher risk of things like cardiovascular disease, hypertension, classic risk factors for stroke. But even when correcting for those factors, the adults with CP still have twice the risk of stroke compared to matched controls. So it's independent of those factors. And this is it's a fascinating clinical research phenomenon. Things that we don't know are the patterns of stroke, the types of stroke, the etiologies of stroke in people with CP compared to matched controls. So these are all areas of research and areas important to think about when we think about stroke prevention in this population. Myelopathy, thought to be due to spondylosis and thought to be tone related. So wear and tear on the vertebra, on the spine, associated with progressive narrowing of the spinal canal and resulting in myelopathy. Adults with CP are at 8 times the risk of spondylosis compared to matched controls. 31% of people with dystonic CP, so with dystonia predominant CP, 31% will have cervical myelopathy by age 36. Now, I mentioned earlier that a third of adults with CP will lose mobility. And I think there is a somewhat ableistic bias in medicine to think that, well, maybe that's just your CP, you know, oh, maybe it's early aging. But there are all of these other things that we should be screening for. And who better than us to be able to pick up on early signs of myelopathy. Who better than us to help ensure that someone's functional status is retained by screening for these things? This is an us problem. So this is something that we should really focus on. Routine screening recommendations for this have largely been in ortho's camp and are recommendations for screening x-rays beginning at 30 versus 50, depending on the phenotype of the person with CP. But again, I would challenge us to say that the phenotype may be best defined by us, and screening for early symptoms of myelopathy may also be something that is best done by us. So this might be something that we should take on as well. Dementia. So there are age-dependent increased rates of ADRD in adults with CP. The most drastic differences are in younger people. So age 45 to 64, that is where that 9-time higher rate comes in. So really at age 45, you might have a 9 times higher risk of having ADRD compared to an age-matched control. At age 65 and up, that's about twice as high as age-matched control. So the reasons for this are unclear. As we know, brain injury, neonatal brain injury is a big etiologic contributor to CP. Does that in and of itself put you at risk for dementia? Possibly. There is a variable genetic association with ApoE4, which is associated with an increased risk of Alzheimer's as well. There's some data that has variably been replicated that ApoE4 is also associated with an increased risk of CP. And because of these overall epidemiologic data, in Sweden, which is one of the bastions of cerebral palsy surveillance and epidemiologic studies, they have formal cognitive screening recommendations at age 24 and 54 for people with CP. So this is already being done in other parts of the world with robust healthcare systems. It's something that we should be considering as well. For epilepsy, so I mentioned that 9% have new adult onset epilepsy, having never before had a seizure. But on the flip side, even though people with CP may have a lesional epilepsy, 50% of people with childhood epilepsy may achieve seizure freedom in adulthood. And if we think about the adults we're seeing in clinic today, the prevalence of meds that may be associated with a high side effect profile, phenobarb, Depakote, these meds are still likely on board, or sorry, valproic acid. These meds are still likely on board for many of our adult patients. So thinking about when was the last time you had a seizure? What were your seizure types? Would you be interested in seeing if you could wean off anti-seizure medications in adulthood? These are things that are worth discussing when you see someone with CP in the clinic, particularly given meds with higher side effect profiles, particularly as people get older. We are getting increasing data through the Cerebral Palsy Research Network that people with CP may be less likely to undergo surgical evaluation for medically intractable epilepsy, even though many will have lesional epilepsy, will have a lesion on brain MRI associated with their epilepsy. I challenge us all to think about why that would be. I mean, I think we can think about access. I think we can think about who's seeing these kids. I think we should really think strongly about how ableism plays a part in how we care for people across the lifespan, and why our presence as adult providers in caring for these people is lacking. So I would think about that very carefully when any provider across any age is evaluating someone with a neurodevelopmental disability. How is ableism playing a role in this clinic today? Loss of mobility. So peak mobility for people with CP is in their teens, and that's across the board. A third will worsen by 1 GM-FCS level following their teens. And this is critically important, so I'm going to go over what GM-FCS is for those of us who are not familiar. GM-FCS is a classification system that was proposed by Peter Rosenbaum and colleagues, and Peter Rosenbaum is one of our really a world-renowned CP expert based out of Canada. And they've established 5 different levels to describe what baseline function is for someone with CP. And that ranges from being able to run, walk, and go upstairs without railings, that's GM-FCS level 1, needing a railing to go up the stairs, but otherwise being able to walk without assistive devices, that's 2. GM-FCS level 3 is needing assistive devices to be able to ambulate, but still being able to walk independently. GMSCS level 4 is needing a wheelchair predominantly to get around, but being able to move that wheelchair yourself with either power assistance or manual. And GMSCS level 5 is requiring someone else to be able to, for your mobility needs, is requiring someone else to be able to move you around in a wheelchair. These levels have been shown to be stable or associated with stable motor function scores, GMFM scores, from about age 7 onwards. That means that if you see someone with CP that describes their function at age 20 as something like a GMSCS level 2, and they're coming to you at a GMSCS level 3, something is very wrong, and that requires investigation, either through imaging, history, or something. It requires a deep neurologic dive. So this isn't something that's just typical and you just wave your hand at. A drop in GMSCS level requires a thorough investigation. The early aging phenomenon and the concept of progression really hits home when we think about adults with CP. The majority of those who can independently walk at age 20 will not be able to by age 60. It's difficult to know what the contributors are. Many of these adults will lose access to physical therapy, to a lot of different services. And there are all of these other things that I outlined: stroke, myelopathy, untreated tone issues, the early aging phenotype that I mentioned. How many of these are modifiable, treatable factors? I think only increased neurologist involvement in the care of these people across the lifespan will be able to tell. So it's possible that we could change these numbers just by seeing these people in our clinics. Something that I'm very interested in is dystonia and dystonia surveillance across the lifespan in people with CP. And one of the prevailing hypotheses in the field is that adults with CP, one of the contributors to loss of function may be newly acquired dystonia. And the data for this is scant, but where it exists, it is convincing. So this is a population of people that was screened for scoliosis in Australia, same population of people. So age 13 to 15, you see about 9% were classified as having dystonia. When that same population was screened at age 29 to 30, that number went way up, didn't it? 44%. So what happened? Was this dystonia underdiagnosed at age 13 to 15, or did these people develop new dystonia? And longitudinal characterization from people that are adept at motor phenotyping like us can really help answer this question and help us decide if we can intervene early to prevent dystonia from emerging in adulthood in this population. Fatigue and sleep, so reported by the majority of adults with CP. Many report disturbed sleep in childhood, but poor sleep, we know, is a huge quality of life tanker. So screening for this is very important in adults with CP, particularly noting that weight gain picks up, incidence of these, quote, metabolic syndrome symptoms pick up. It's possible that screening for sleep issues can help address some of these other factors. And then pain, again reported by the majority of adults with CP. What might our role be here? Thinking about central pain syndromes, thinking about the same sort of pain syndromes you might see in our patients that have had stroke. What is this if not some version of a stroke-like phenomenon in early life? So thinking about treatments that can help with central pain syndromes may be helpful for this population. And it's also of note that undertreated tone in adults with CP is associated with pain as well. So making sure that we have tone management in check, particularly dystonia management, which is something that maybe uniquely in our wheelhouse, is something that's important to caring for this population. You may see that we referenced this paper throughout this talk. This was something that we published a couple of years ago with many members of the AAN Adults with IDD section, jointly with members of the Cerebral Palsy Research Network. And in it, we do a systematic review of the data that's available on neurologic manifestations of CP in adulthood. But we also give people kind of a crib sheet for how you might use this to change your practice. And we do this for neurologists, But we also felt very strongly about doing this for adults with CP and the people who care for them, and for clinical researchers as well. This is something, caring for this population, doing right by this population will require a multimodal approach. And part of this is on us as pediatric providers and adult providers to educate our patients about what they can do to advocate for themselves. Until there are enough of us out there, we have to provide, this information can't stay within us. We have to provide it to our patients and their families so that they can advocate for themselves. We highlight things that people can do, neurologists, people directly affected by CP, and researchers for investigation of etiology and stroke, for myelopathy, mobility loss, spasticity and dystonia management, and for dementia, epilepsy, and fatigue and pain. And you see this table goes on and on. Just to kind of break this down into key components, we do recommend that everybody with cerebral palsy has a baseline MRI on file. And the reason for that is that if you have a change in function, it's nice knowing where you started from. So it may or may not shock you how many adults with CP have never had an MRI done. And the stories that we've heard about, oh, well, I had an MRI done for this study and someone told me I had something called periventricular leukomalacia, and I never knew that that was the injury pattern associated with my CP. It's both hard, it's sobering, I guess. I was going to say it's heartbreaking and also has promise, but it's sobering. It shows us how much opportunity we have to improve. And establishing that baseline MRI and associating that with repeat imaging, if there's a drop in function, is critical. That will really help identify, does this person have a new stroke? Does this person have evidence of myelopathy that can be addressed? These are important things for us to keep in mind. I would encourage everyone, when they see someone with CP in clinic, and that's across all age groups, to establish an etiology and to consider strongly genetic testing for this population for the reasons that we've already outlined. Clearly document the baseline. And this is something as a neurologist that we often harp about, but in particular in people with CP, documenting the baseline is important because you don't want that person to go somewhere else and have all of their concerns dismissed because it's just their CP. So making sure you have that baseline documented, including a GMSCS level, can be really valuable in letting people know that, hey, this is a big change. This may not be just their CP. This requires a thorough evaluation. And making sure that that documentation of baseline is not just can they walk, yes, no. It's also including motor phenotyping, because that should guide our pharmacologic and potentially surgical management of tone for these patients. Evaluate the ongoing need for anti-seizure medications in these patients. Up to half may not need them anymore after having childhood epilepsy. And something really important that we should take on is to educate people about the coexisting issues that they may face as adults with CP, and also to ask about sleep, ask about pain, screen for seizures. If you know that people are at high risk for these things, ask about them. And even asking about them is an act of advocacy. It's an act of education. It lets people know that it's important to think about these things. And maybe the next time they see a different provider or they're admitted inpatient somewhere else, they'll know to say, these are the things that I, as an adult with CP, should be screened for. And that's just by having a visit with that person. That's something we provide. So we've talked about cerebral palsy, how to diagnose it, etiologic evaluation. We've talked about neurologic manifestations, and I hope we've convinced you all to join us on a bit of a crusade of thinking about neurodevelopmental disabilities across the lifespan. This is, obviously something I'm very passionate about, and as a pediatric practitioner, and it is a blessing to be working with adult practitioners on this issue as well, and to be partners with the community of people affected by neurodevelopmental disabilities as we think about this webinar series. I would also encourage everyone on this call to think about the neurologic organizations that they belong to and compel them to provide educational information about everyone with neurologic conditions. And that includes CP, that includes neurodevelopmental disabilities. So I hope you'll join us in that effort. This is my personal contact information. And with that, I'll call it and see if someone else wants to talk other than me. Thanks, everybody. Okay. I see that Seth has his hand raised. Go ahead, Seth.
Booma, that was really outstanding. Thank you very much. I mean, it just draws attention to the issue, which is so important. I'm an adult neurologist, so I don't really see children. And I think the big issue is really the transitioning of care from the pediatric neurologist to the adult neurologist who doesn't know what they don't know what they don't know. Wouldn't you say that's kind of really what the issue is, right?
Absolutely. Yes.
Yeah.
So obviously establishing transition and transition plans is a hot topic. This is something that, I mean, as an example, we can talk about ways that we can advocate for that and things that we can do in real time.
Right.
Training is critical. I think when we think about the PEDS experience that our adult trainees, adult neurology trainees get, it may be a few weeks on inpatient where you're not seeing what a longitudinal care plan might look like for people with neurodevelopmental disabilities that should populate adult clinics. So I think when thinking about training paradigms for adult neurologists, including exposure to many of the multidisciplinary care clinics that are available at a lot of our pediatric centers is important. And barring that, including outpatient exposure is critical. So thinking about that from a training perspective and thinking about when you're educating an adult resident and you see a patient in clinic with them who's pediatric, talking about when this child goes to you, this is what I think you should do. That sort of mindset is important. And then in real time, I think it can be very hard for families in particular and the people directly affected by cerebral palsy, which is my specialty, so I'll just speak to that. It's a hard jump, right? To go from your home, and it is your medical home in pediatrics, to go to a paradigm where the neurologist is often not the care quarterback. And I will say that I think it is unreasonable to ask all adult neurologists to assume the role that many pediatric neurologists assume and become the care quarterback for these families. But I think what we can do is identify adult neurology partners that are willing to meet us halfway, meaning that, for example, what we're trying to do at WashU, and I see that Mike Boving is on the call, he's one of our adult PMR colleagues at WashU. What we'll be trying to do is do joint clinics for our adults with cerebral palsy, where you have a pediatrics provider and an adult provider who's seeing them in the same clinic day, and do that for a year or two, and then establish that sort of gradual transition where the adult provider sees how you care for this person and then can take them on afterwards. This won't work everywhere. We're lucky to be at a large center, but it's one paradigm that we're hopeful will work for us.
Yeah, Booma, can I just add one extra comment? I'll let other people certainly talk in the remaining time. Is the issue also of stigma, stereotypes, biases? I think that's huge because, right now we want to care for people, but you actually have to care for them. You actually have to think of them as having value. So I think there's inherently, unfortunately, a lot of biases that go into someone with quote unquote cerebral palsy. One, that they're less valued, and also, which is a sensitive issue, is that they absolutely may not have an intellectual disability. It might be more of a motor dysfunction, even speech difficulties, which is certainly very prevalent. And so I think, again, education and training for those caring for them have to be very, very super open-minded about the individual and not put barriers and limitations about this person can't do this, they'll never do this, because that really would set a really bad precedent for relationship building.
Absolutely. Agreed.
Yeah, so thank you. That's my little soapbox comment.
No, I totally agree. I mean, again, I would challenge all of us to think about the inherent ableism in all of us that we need to combat actively in every medical visit.
Thank you.
I see that Danielle Barber, Dr. Barber Zipen, makes a comment for an outstanding case for MedPeds trained neurologist. Gosh, I would love that. That would be wonderful.
What's the difference? Because all child neurologists are also trained in adult neurology. So do they really have to do med peds and neuro? Or could someone do child neuro or NDD and have, I think of child neuro and NDD as the med peds of the brain. because we're
Dr.
trained in
Barber, are
both.
you available to unmute and discuss that point a little bit?
Sure. Sorry, I'm you may hear some kids soccer in the background.
That's great.
But yeah, I mean, I think, for example, I agree with you theoretically, but I for example, do transition my patients once they reach 21 years old, because I only have limited clinic spots, and I try to focus on the pediatric populations that primarily. But theoretically, yes, we could keep our patients. I think, though, there is also, you know, as Dr. Aravamutan explained, you know, things that are not on my radar, like stroke and myelopathy, that are not that that's not a peds issue. It is, but it's not. It's I don't know. I think they do become adults, and they should be cared for by adult competent providers. Just like caring for children is not the same as caring for adults, I think vice versa is also true. So
absolutely. No, I completely agree. And I also agree that it's not like we want to keep these patients in pediatric settings to take up the valuable spot, but I am just wanted to open the discussion of what is the right training pathway. And I really appreciate your idea of med peds. I work with med peds people all the time and almost went into med peds myself. So I just think it's an interesting point to be, well, if they train in medicine and pediatrics, why not have a training pathway of training in child neurology and adult neurology, where your goal is to practice adult neurology with that pediatric knowledge? Just like med peds, we think, oh, that's perfect because they'll treat adults with childhood onset conditions. But could we have neurologists working in adult capacities that have experience with childhood onset conditions and make that more of a pathway and more of something that is hiring and people are looking for and want to support? So
yeah, totally. I really like the comment about, you know, we each train on the other side, right? So when child neurologists are training their adult neurologist colleagues during residency, you know, make a case of this is what you're going to have to think about when you are caring for the patients that have transitioned, and vice versa. So I think that's really valuable.
I also think that it is the care model that it would be great if an adult neurologist were to establish a multidisciplinary care clinic that looks exactly like my multidisciplinary care clinic as a pediatric provider. I think we need to disavow, as pediatric providers, pediatric neurologists, I think we need to disavow ourselves of that a little bit. And I think inviting adult providers in to what our care setting looks like, so that they can reasonably replicate the aspects of that they can replicate for their families, their patients, and then think about how they can connect with other providers to give the other aspects of what we provide in a multidisciplinary care clinic is important. I think we can't expect that adult neurologists serve as the care quarterbacks like we do, but it's our role, I think, to train both trainees in the conventional sense, residents, and also work with our colleagues to let them know that this is how this family has been cared for their whole lives. We really need you to think about that when you're setting up how you want to care for this family after they leave this setting. And a part of that could be just bringing people in to the PED setting and figuring out billing and how that would work. And a part of that is letting go of the notion that the way we do things is the only right way to do things. I mean, I think I'd engage in a lot of finger wagging historically, and that's not the way to go about this. I mean, there are different ways to care for people, and as long as we ensure that a family's needs are met, that just because this is the way they've always experienced things doesn't necessarily mean it's the only way that they can experience things.
I could just be a little bit contrarian and just say possibly to consider eliminating the word of transitioning, and because it's really just a if you look at a little different approach conceptually, you look at this as a developmental stages, and the adult is just another developmental stage. So it's really a continuum. It's a lifespan type of problem in a sense, whatever it may be, developmental disability or motor disability, et cetera. So if we get more into this concept of continuum and try to arbitrarily cut things off at a certain age, that might get more people involved. I don't think physiologically there's much difference between a 19, 20-year-old and a 25-year-old in the sense of how we're treating them from a neurological perspective. There's, some bigger differences as they get much older, but it's really just a continuum of care. And we're trying to create artificial cutoffs that really vary by the individual, just in terms of personalized medicine, the concept is going to change depending on the individual. And the concerns, I think, also from trying to treat adult issues as a pediatrician and also as an adult trained physician treating people with childhood disorders, I think there's a little bit of maybe too much emphasis on that, is that because we don't really necessarily, we just focus on what we're comfortable with. So you don't have to necessarily worry. Let's say as a child neurologist trained individual person, you don't necessarily need to worry about someone might have multiple sclerosis or something else, because that's not what you're going to focus on. You might be focusing on the developmental disabilities, which you have good expertise in and are very comfortable with, and it doesn't really matter if it's manifesting in a 30-year-old or an 18-year-old or a 12-year-old. In a sense, it's just a continuum of the developmental disability. But if they have a superimposed disease that's more adult-based, when they have issues with hypertension and adult diabetes that you're not comfortable with, I mean, that's not something you're going to be managing anyway. Well, Warren brings up too in the chat box there about how do you get general adult neurologists to know more about what they don't know? I mean, that's a challenge, and you might and it might not be something that's solvable. I mean, it's if they don't have necessarily interest.
Well, I think it is solvable. I mean, what is interest, right? I mean, when we think about our premier neurologic organizations, they set the tone for what is important to know about neurology. And if we only keep talking about cerebral palsy at Child Neurology Society, and it doesn't infiltrate the educational offerings of professional neurologic organizations at large, then that is a problem. So I think it is important for all of us to compel the leadership of our professional neurologic organizations to provide education on neurologic conditions across the lifespan, not just conditions that start in adulthood, conditions that start in childhood and persist throughout adulthood. And that is neurodevelopmental disabilities.
Right.
So a part of what we're hoping to do is provide a venue for that here, but every single opportunity, every single venue that we're providing, I hope that the people on this call will go to their professional neurologic organizations and say, maybe you should be providing this so that neurologists at large can hear this. I mean, that's where we go for our CME. That's where we should be hearing this messaging.
And the patient population, and also the people themselves with cerebral palsy and their caregivers, I mean, they can't be too happy that, their adult neurologist doesn't know squat. So they themselves as advocates also will be on this as well, which they certainly are. They're frustrated, they're upset. It's hard to find, people that know about it. It's not fair. It's really a civil rights violation as far as I'm concerned.
Well, what they do is they find in all these situations, it's also in the area of child neurology, for example, if we don't focus on certain things, people are still going to find a way to get care. So on the adult side, and probably they're migrating towards physiatrists,
right,
chiropractors, I mean, other people who are willing to listen to them and take care of them and take their situation and try to provide some therapy rather than try to get frustrated by going to neurologists who says, well, I don't know too much about that, or I can't help you too much. So they're going to find care. It's just not going to necessarily be but so the neurologists have to embrace these things. And if we say cerebral palsy is a neurological disorder, then we need to be able to assess.
They have a voice though
across the lifespan. No, I agree with you. No, that's what I'm saying. No, I'm saying they have a voice, but I think I guess what Boom was sort of alluding to also. I mean, it's the concept is that you have to really define who your patients are in a certain field and then embrace them and not just sort of be very selective and say, well, I'm a neurologist, I'm not going to see ADHD, let's say, because that's not, or I'm not going to take care of the ADHD because I'm taking care of the epilepsy. But you know, if it's a brain disorder, if it's coming from the brain, I mean, these are our patients. You got to embrace and treat the whole patient and not be very selective and just say, I'm only going to do the epilepsy and only do the seizure. And the same thing with all these other disorders. Talk about developmental disabilities and motor disabilities. I mean, these are our patients. These are our cohorts, and as a scientific and clinical field, we have to embrace them and provide a way to provide services, or they'll just find services elsewhere. I mean, they're not going to wait
Or
around.
not find anyone, which happens a lot.
And that could happen also, but I think there's enough, you know, sort of overlap in so many different fields now that that you can, you know, find services to some degree. But yeah, true. I mean, you could also, because also just outside the medical field too, in a sense. I mean, there's therapists of all different shapes and sizes that can then, you know, fulfill a need, at least in terms of their motor disability. Or
Yeah, I mean, I guess, I mean, just to kind of close with this message, because I think we're over. I think even though there are providers that can fill this role, adults with CP often do not find therapists, providers to fill this role. And part of that is an insurance reimbursement issue. And a part of it is, you know, it gets pretty tiring to keep going to people and having them say that you're not what I do. And that hitting that wall over and over again is demoralizing. And then you end up in a why bother kind of phenomenon. And it's difficult. It's difficult for adults with CP. It's very difficult. And it's, I mean, let's start here, you know, let's start here. There's a lot of room for improvement. There's a lot of opportunity to grow. There's a lot of room for advocacy and for telling our colleagues that this is important. So I'm excited for the start with you all today. And I look forward to seeing you all next month for our next webinar, which I believe is December 20th.
Yes,
at 5
Tuesday,
p.m.
December
Central.
20th.
Yes, Tuesday, December 20th, 5 p.m. Central, 6 p.m. Eastern. We'll have the next installment of the series at that time. Same Zoom link. And so we'll see you all here again next month. Thank you.
Thank you.
Thank you.
Thank
Thank
you.
you.
Bye-bye.